Bismillah ar-Rahman ar-Rahim. This is the first video in a series of videos discussing the young adult hip problems. We will start with understanding acetabular dysplasia. Why young adult hip? I will start by referring to a paper from the British Medical Journal published in April 2018 addressing the general practitioners how to approach a hip pain in a young adult. They pointed out clearly that hip pain in young adults is not normal. We are all aware of what we name the non-specific low back pain. However, this paper pointed clearly that we should understand that there is nothing called non-specific hip pain in young adult, and any hip pain in a young adult should be properly investigated. They pointed out also that causes tends to receive less attention in a young adult than in the geriatric or the elderly group. Lastly, imaging studies might not reveal an underlying problem because changes may not be apparent for a GP. However, as an orthopedic surgeon, you should be very aware of the radiographic analysis of a young adult hip. Looking at the causes of a young adult anterior hip pain or groin pain, they divided them into an orthopedic causes and a non-orthopedic causes. Orthopedic causes, the hallmark of the examination will be its relationship to hip movement and position, and others, they are not related to hip position or movement. Looking deeply into the orthopedic causes, we will find that the femoroacetabular impingement and the adult acetabular dysplasia comes first, followed by other less common causes like osteoarthritis, stress fracture, avascular necrosis. And you have to keep in mind that thinking of these two things comes first before thinking of less common things. This is another paper or another table coming from another paper from our orthopedic literature, causes of persistent anterior hip pain. Intra-articular causes where you find that dysplasias comes first, followed by hip impingement. These are our learning objectives in this video concerning acetabular dysplasia. First, we will start with the definition. Hip dysplasia means there is an abnormality in the shape or the size of the acetabulum or the femoral head, or their proportions or alignment in relationship to one another. Most commonly, it's found on the acetabular side. Hip dysplasia, or acetabular dysplasia especially, is a leading cause of early osteoarthritis in young adults. In a report coming from the US, they found that patients undergoing total hip replacement less than 50 years old, 50% of them were found to have an underlying degree of acetabular dysplasia. The pathology of acetabular dysplasia is purely a mechanical problem in which there is a deficient bony acetabular coverage to the femoral head, resulting into a small contact area between them. This will result in an increased contact pressure in the hyaline cartilage per unit surface area, and this will result into early wear proportional to the degree of dysplasia. The femoral head itself is not normal. It's usually ellipsoid with a thicker neck and an abnormal neck shaft angle. Looking at the soft tissue, in response to deficient bony coverage, the soft tissue will compensate to the overloads or will react to the overload on it by compensatory hypertrophy of the labrum and the capsule. If we divide the progress of the pathology into three stages, the first stage is bony undercoverage, resulting into increase in the contact stresses, bone respond by sclerosis, labrum and capsular and soft tissue respond by hypertrophy. On the second stage, after years of overload, failure starts after degeneration and results into tear. At that point, the patient starts feeling pain. Finally, the end stage comes where head subluxes after soft tissue tears and degeneration, resulting into incongruency and secondary osteoarthritis. All these changes occurs at the rim of the acetabulum, and that's why we name it acetabular rim syndrome or premature aging. Looking at the location of the pathology in acetabular dysplasia, all these changes occurs in the anterosuperior quadrant, where the bone is deficient in this area. Going to the classifications, if we look in the literature for the classifications of acetabular dysplasia, we'll find that most classifications are arthroplasty oriented. However, in 1991, Gans and his Bernese hip group, they published this article, Acetabular Rim Syndrome, in the JBJS, and they divided the acetabular dysplasia into two groups having different radiological features with different pathologies. Type 1 is radiologically incongruent, in which the radius of curvature of the acetabulum is much bigger than the radius of curvature of the head, while in the type 2, which is the congruent type, the radius of curvature of the acetabulum is very close to the femoral head. Based on these observations, they noticed that soft tissue lesions usually occurred in the incongruent joints, while the bony lesion occurred more in the congruent types. To understand this more, if we look at type 1, which is radiologically incongruent, here the acetabulum is shallow and vertical, and that's why its radius of curvature is much bigger than the femoral head. Here the hip is potentially unstable because the acetabulum is vertical, and there is an abnormal shear force that usually forces the hip to subluxe or forces the femoral head to subluxe outwards, pushing the labrum and the capsule to the outside, leading to its tear and detachment later on. While in type 2, the radiologically congruent type, the acetabulum here is only a short roof with less than normal coverage. And that's why the radius of curvature of the acetabulum and the femoral head is very close to each other. The hip here is a potentially stable one, only there is high stresses on the rim of the bone, leading to abnormal remodeling, intraosseous cystic changes, and later on osteoarthritis. This may result into a fatigue fractures of the rim of the acetabulum. Another classification, which was suggested in 2013 by Nagasaki from Japan, looking at the relationship between the femoral head and the degree of acetabular dysplasia, he noticed that there is a significant correlation between the femoral head deformity and the severity of acetabular dysplasia. So, if you have an abnormal acetabulum, usually this is associated with an abnormal head shape. To summarize the first part of our presentation, definition: it's a mismatch between the femoral head and the acetabulum. Pathology: it's a bony and a soft tissue lesions occurring all at the acetabular rim, which is located mainly in the anterosuperior quadrant of the hip. Classifications: we can classify them into two types: incongruent type with more soft tissue lesions, and a congruent type with more bony lesions. Diagnosis: diagnosis of acetabular dysplasia in early stages is very difficult, and it should be suspected in any young adult coming with an anterior hip pain or a groin pain related to hip movement and position. Usually, a young adult presents with a hip pain. However, in sometimes, clicking is detected, and this clicking may result from two things. First, labral degeneration and later on tear, or the most common is a hyperactive iliopsoas muscle. In acetabular dysplasia, usually the iliopsoas muscle is hyperactive and sometimes hypertrophied to compensate for the deficient bone in the anterosuperior quadrant of the hip. And this may result into what we name internal snapping and a click on movement of the hip. Clinically, there is no specific single test for detection of acetabular dysplasia. However, these patients have pain with range of motion testing. Usually they have positive impingement tests, which is flexion, adduction, internal rotation. On this maneuver, they usually feel pain because of stressing the degenerated or the torn labrum against the femoral head. So, a clear diagnosis should be made on a basis of a positive clinical data and examination, plus a positive radiological findings. To radiographically diagnose an acetabular dysplasia, we only need a true plain AEP view of the pelvis. Usually, we rely on these criteria for diagnosis. Lateral hip subluxation. Usually the head is far away from what we name the teardrop or the floor line. Deficient anterior wall. The anterior wall is medial to the femoral head in severe cases. The most diagnostic angles is the lateral central edge angle, which is normally more than 25 degrees. However, in borderline dysplasia, it's between 20 and 25. In severe dysplasias, it's less than 20 degrees. The tonus angle or the acetabular index is usually positive, more than 10 degrees. And finally, looking at the neck shaft angle, it's usually in a coxa valga with more than 135 degrees. The preoperative assessment is done by having a weight-bearing radiographs and an abduction views. Weight-bearing radiographs to assess the joint space and the need for total hip if it's arthritic. Abduction views is needed to assess the congruency and the coverage that you will get after your reorientation osteotomy. And finally, a CT scan to help you to plan for your osteotomy. Treatment of acetabular dysplasia usually relies on a procedure that will cover the uncovered head. In literature, this was done either by an extra-articular techniques without opening the capsule, using a shelf arthroplasty or a Chiari osteotomy, and these are relatively easy. However, they address only the problem of instability, and they do not address the main pathology of the rim overload. However, the most popular is the reorientation osteotomies, like the tonus or the very popular periacetabular osteotomy or the Bernese osteotomy in Europe and North America. However, these types of reorientation techniques is technically demanding, but they address the pathology and stop the overstress on the rim. To get a good results after your osteotomy, you have to have a patient less than 40 years with a body mass index less than 30 and no osteoarthritis, and on an abduction view the head is congruent with the acetabulum. The Bernese periacetabular osteotomy is usually done through an anterior approach, a Smith-Peterson approach, and usually it is composed of 5 cuts for the periacetabular tissue. Finally, a reorientation of the acetabulum. The first cut is the ischial cut, separating the acetabulum from the ischium. This is usually done anteriorly using a special curved osteotome, the Gans osteotome. This osteotome has a special curvature and a special features that allows rotating around the acetabulum, separating it from the ischium bone without harming the posterior column. The second cut is the pubic cut, separating the acetabulum from the pubic bone. And this is done in a regular fashion using a regular osteotome. Finally, the Ilium Cuts. We start with an iliac wing cut in a direction from distal to proximal after doing an anterior superior iliac spine osteotomy, stopping 1 centimeter above the acetabular rim. Finally, the posterior column cut. You reorient your osteotome in another direction, passing between the greater sciatic notch and the posterior wall of the acetabulum inside the posterior column, separating the acetabulum from the posterior column and preserving it. Finally, the last cut is an osteoclasis cut, and this is done after putting a shank screw into acetabulum, starting to reopen the acetabulum until these two limbs are connected. Finally, you're left with a good posterior column, our preserved posterior column. Reorienting the acetabulum. Usually to cover the head, we put the acetabulum into an internal rotation, forward tilt or an external rotation with a medial rotation. Finally, reorienting the acetabulum to cover the antero-superior uncovered quadrant of the head. The final step is fixing the acetabulum in the new position with the stationary screws. After doing the fixation, we usually open the capsule to remove the bump at the antero-superior quadrant of the head in an ellipsoid head to prevent later on impingement with flexion of the hip. So the advantages of this osteotomy: it's a reorientation osteotomy. It preserves the integrity of the posterior column and preserves the pelvic shape, especially in a female for pregnancy. And finally, it preserves the outside structures of the hip, which is the hip abductors. Looking at the results of literature of this procedure, this is a review of different reports coming from different parts of the world with a long-term follow-up showing a good preservation of the normal hips in a good percentage of cases. However, this procedure is technically demanding with a lot of complications. These complications were reported in Gans' early experience. In this report, Gans reported that this procedure has a steep learning curve, and he reported that 85% of his technical complication occurred during the first 50 procedures. Finally, looking at some examples. This is a radiograph of a female, 33 years old, complaining of left groin pain from 2 years. She was referred as having a femoral acetabular impingement. With a closer look, she has a deficient edge angle. She had a positive acetabular index and a deficient antero-superior coverage. Periacetabular osteotomy was done successfully for her, and here is the 3 years follow-up of her of her hip and function. Another case of a female, 37 years old, right hip pain from 1 year, referred as having an avascular necrosis according to the MRI report. However, this was not an avascular necrosis. This was the subchondral cyst found in the acetabular and the femoral head sides. After doing bilateral periacetabular osteotomy, this is her 3 years follow-up, and finally the 5 years follow-up with a good hip function and radiographs. The last case is a male, 36 years old, wrongly diagnosed as having femoroacetabular impingement, operated upon by a hip scope, and finally still complaining. With a closer look at the X-ray, you will find that his borderline dysplasia, periacetabular osteotomy was done, and finally this is his follow-up X-ray and function. Finally, in summary, young adult persistent hip pain is not normal and should be properly investigated to reach the underlying cause. Hip dysplasia is common and is often overlooked. Diagnosis relies on a positive clinical plus a positive radiographic findings. Any positive clinical or radiographic signs alone is not diagnostic. Both together are diagnostic. Treatment: try to do a reorientation osteotomy as soon as possible to preserve the hip. Thank you.